Welcome everyone to the Center for Global Development virtual events platform, and thank you for joining us. My name is Carly Krupener, and I'm a policy fellow in global health here at CGD and one of the co-leads on a project supported by Open Philanthropy, looking at indirect health effects of COVID-19. Today's event, co-hosted by Gates Ventures, is the first in a series examining how the COVID-19 pandemic may be contributing to indirect health effects in various country settings. Today, we'll be taking a closer look at the experiences and findings from Kenya and Uganda. Before we get into the presentations and panel discussion, we wanted to encourage you all to join the conversation and submit questions to our panelists, which you can do by tweeting at CGDev using the hashtag CGDTalks. You can also email events@cgdev.org or submit your questions or comments via YouTube. So as many of you know, the early stages of the pandemic were marked by a critical focus on preventing COVID-19 cases and deaths, as well as the resulting strain these cases could impose on already stretched health systems. And with this narrower focus on COVID, many policy responses employed stringent social distancing and lockdown measures. Yet as many countries adopted lockdowns and repurposed health resources for an all hands on deck COVID response, there were serious concerns about the potential effects these response measures could have on meeting other essential health needs during the pandemic, not to mention what fear of COVID itself might do to care seeking. Early projections on indirect health effects painted a bleak picture. A WHO analysis predicted as much as a 23% increase in malaria-related cases across sub-Saharan Africa and a potential doubling of malaria-related deaths, largely concentrated in children under 5. There were also alarm bells for disruption to routine childhood immunizations and vaccine preventable deaths, with one study noting that as many as 117 million children worldwide were at risk of missing out on measles vaccinations. Meanwhile, Guttmacher modeled that a 10% reduction in sexual and reproductive health services could translate to an additional 28,000 maternal deaths, 168,000 newborn deaths, and over 15 million unintended pregnancy. And there were similarly dire warnings about lost progress in the fight against HIV and TB. So now here we are a year after the pandemic was declared, and we have some initial evidence to show us what has actually been happening across different country settings, looking at various health indicators and the kinds of disruptions we're seeing, or in some cases not seeing, for different health services. The findings from these country case studies can shed light on the magnitude, duration, and source of disruptions, as well as what more can be done to mitigate indirect health effects and maintain services during ongoing response measures or in subsequent crises. They can also help us think through about future areas for investment to close newly created gaps in health access and work toward more resilient essential health services. So to kick off the discussion today, I'm going to turn the floor over to our colleagues from KEMRI who will walk us through their findings from Kenya. We have Ms. Stacey Orangi, a research officer in the Health Economics Research Unit at KEMRI Wellcome Trust. Stacey's research interests and experiences focus on economic evaluations and the economics of health systems, as well as her colleague, Mr. Jacob Kazungu, a research officer in the Health Research Unit at KEMRI Wellcome Trust, who has an interest in health financing, equity analyses, and using stated and revealed preference methods to improve health systems in Kenya and across sub-Saharan Africa. Stacey and Kazungu, over to you.
Thank you very much for the wonderful introduction and the opportunity to present our initial findings in this forum. My name is Jacob Kazungu. I'm a research officer at KEMRI Wellcome Trust. And I'm here with my colleague, Stacey Orangi. And we are going to share early findings about the indirect effect of COVID-19 in Kenya. Slides up, please. So in Kenya, so This presentation is all about what do we really know about COVID-19's impact on essential health services, and we're sharing early evidence from Kenya and Uganda. Next. So in Kenya, we assessed the indirect health effects of COVID-19, and this work was led by Professor Edwin Barasa, myself, Stacey Orangi, Maurice Ogero, and Kandoni Kasera. Next. And this will be the outline of our presentation. So we have a short background, methods, the key findings, and conclusion. Onto the background, Kenya is among the countries which was net spared with COVID-19. And as of March 27th, we had recorded a total of 129,329 cases. And a majority of these cases were among the males. And we had around 2,104 deaths. And as you can see on the graph, we are now on the third wave, and it seems to be, we are recording the highest numbers now than in the two other waves previously. So we are yet perhaps to see the full wrath of the pandemic in terms of cases in Kenya. Next. And to respond to this, the government came up with a number of strategies, including physical distancing measures, where one, for example, the government banned all gatherings, including political gatherings as well as social gatherings, sanitation or hygiene measures, the recommendation to wash your hands with soap and running water, as well as use of sanitizers. And then it restricted movement in some of the counties where they were COVID-19 hotspots. And then it also closed learning institution, although this resumed a bit, but then was closed again. And then we still have a nationwide curfew from 10 p.m. to 4 a.m., although this has varied across the period. Next. And the reason for all these measures was to help slow down the transmission of the virus, with the goal of flattening the rising curve in the number of COVID-19 cases in Kenya. But most importantly, was to sort of borrow time for the health system to enable it to absorb the healthcare needs of COVID-19 patients, as well as for other patients with other conditions. And again, it was essential to put this up to reduce the likely morbidity and mortalities due to COVID-19. But as we will show, in as much as perhaps these non-pharmaceutical interventions have had positive effects, they could also have resulted into unintended health, social, and economic effects. So in this presentation specifically, we're going to look at the indirect health effects of the pandemic in Kenya. Next. So to look into this, we involved a mixed method approach, involving both a quantitative approach and qualitative review. So for the quantitative approach, we selected indicators on the table on your right. We selected 7 indicators representing key disease areas or services, including health facility outpatient visits, health facility inpatient admissions, childhood immunization, maternity and sexual violence. And then for the period from January 2019 to November 2020, and conducted an interrupted time series analysis to evaluate the impact of COVID-19 on the level and the trend of selected utilization of these key indicators, using March 2020, which is the month where Kenya recorded her first case of COVID-19 as the event month. We also did qualitative inquiry, which involved key informant interviews to basically explore COVID-19, the effect of COVID-19 on health system disruptions. So in key areas, health financing, supply chain, health workforce, health infrastructure, as well as service provision and patient access. So we did 12 of these key informant interviews across these different categories. Next. So on to the results, the quantitative results. The trends prior to the event were not significant, except for measles vaccination coverage, where there was a declining trend in measles vaccination coverage before March 2020, but during the event month, during the event month in March 2020, we actually saw an increase in measles vaccination coverage by almost 44%. But in terms of bed occupancy rate, during March 2020, there was a decline in the percentage of bed occupancy rate, and this was significant. And moving forward to post-event trend, next. Only 2 of the key indicators examined had significant difference, and this was A and C coverage, which indicated to increase significantly after March 2020 at a rate of 1.10 per month, and then also the number of sexual violence cases per OPD visit increased after March 2020. So this, especially the evidence from the number of sexual violence cases per OPD visits after March 2020 indicates, a higher increase of the cases, and this was significant as opposed to, before the event itself. Next. So these are just diagrammatic representation of the findings, and this was the bed occupancy rate. So we had an increasing trend prior to March 2020, and then it declined during the intervention month, and then increased a bit, although insignificantly, after March 2020. And then the other one next is on sexual violence. So it was declining, although insignificantly, before March 2020, but it's again, there was a step increase, although not significant, but it increased significantly after March 2020. Moving on to the qualitative results. Next. Stacey.
So thank you, Kazungu. On to the qualitative results. We sought to see what the effect on funding for essential health services was, and we found that funding for essential services appeared not to have been substantially affected, although there were efforts to reallocate and reprioritize funding by donors. And this was based on savings from planned activities that were no longer feasible and replenished funds. Next, please. So as we can see, a quote from one of the staff members in the HIV program, they mentioned that I have not seen any budget cuts for our HIV program because of COVID-19. I think part of the savings that we had on our Global Fund grant was used to support COVID-19. We have not been affected. Next, please. In terms of supply chain for essential health services, we found that local supply chains were not disrupted due to pre-existing measures. So for instance, we saw that the National TB program had adequate 6 months stock at the central stores, and TB facilities had a buffer of about 3 months TB drug stock. However, importation of some health commodities for local use was substantially affected. In the malaria program, for instance, supply chain challenges for RDTs being delivered in time was an issue initially. We also find that there was reprioritization of some commodities for COVID. For instance, the cancer control program faced challenges with supply of personal protective equipment. However, despite this supply chain initial challenges, the Ministry of Health employed strategies such as leveraging on a network of development partners to supply commodities whose supply chain had been disrupted. Lastly, we found that there was active monitoring of stock levels using supply chain information system and virtual platforms. Next, please. In terms of the impact on infrastructure and healthcare workforce, we found that there was reallocation of staff and infrastructure to the COVID-19 response. There were also concerns by health workers on the risk of infection because of the scarcity of personal protective equipment. Next, please. So we see a staff member from the malaria program reporting that part of the staff who manage malaria services, such as disease surveillance officers, malaria coordinators, and lab officers, were redeployed to support the COVID-19 response. This included the management of the quarantine centers. Next, please. So we also found measures were taken, and this included transfer of patients to alternate facilities, procuring and distribution of personal protective equipment, protocol development and training of the staff on COVID. One of the HIV program staff reported that they transfer the clients out to the nearest facility, which provides HIV services. Clients are now able to access services from that facility. There's no client who has been denied drugs because your facility has been closed. Next slide, please. Then in terms of the impact on service delivery, we found that there were disruptions in service delivery activities, such as the distribution of long-lasting insecticidal nets and access to services because of physical distancing measures. However, there were adaptations to service disruptions, such as the use of virtual platforms for some of the delayed activities, and for some disease treatments, there was a longer drug collection schedule that was adapted. Next, please. So one of the TB program staff member reported, the TB program immediately responded by revising the schedule of the drug collection. We also did a lot of technical assistance by visiting counties and providing support to optimize case detection and discuss strategies on how to bring back the case detection to optimum levels. We also try as much as possible to be online and provide online support to the health providers through WhatsApp. Next, please. So in conclusion, we found that in Kenya, the quantitative findings were mixed. So for instance, we see statistically significant reduction in inpatient utilization and an increase in the number of sexual violence cases per outpatient visit. In terms of the qualitative findings, we find that there were international supply chain, health workforce, health infrastructure, service provision, and patient access were disrupted. However, the negative effects were thought to be transient, with mitigation measures leading to a bounce back. And our findings in Kenya provide insights into the likely early effects of the pandemic and its mitigation measures in Kenya. Thank you. And we'd like to acknowledge the Center for Global Development, KEMRI Wellcome Trust, and Ministry of Health Kenya, who are all supportive of this study. Thank you.
Great, thank you so much, Kazungu and Stacy. Let's queue up our next presentation from our colleague from Makere, who will present the findings from Uganda. We have Dr. Nazarius Tumwazige, an associate professor and the most recent past chair of the Department of Epidemiology and Biostatistics at Makerere University School of Public Health. His research interests include data analysis, intervention studies, monitoring and evaluation, applied epidemiology focusing on injury and alcohol. He's a member of one of the advisory teams for COVID-19 in the country and has published about lockdowns in Africa and their effects and challenges. Can we advance to the next slide, and then I'll turn it over to you, Naz. Great. Oh, Naz, I think you're on mute.
Thanks so much, Carrie, and thanks everybody for attending this presentation. So my names are Nazarius Mbona Tumaisije, and I'm working together with Claire Bilibawa, Dennis Okethwango, and then Mary Kacho. So let's go to the next slide, please. Yeah, so these are the things I'm presenting, just simple introduction, methods, results, and conclusions. Next. Now, it's over one year when the first case was reported in this country. And initially, WHO had recommended lockdown measures along with the social distancing, staying at home, and hand hygiene. And then several countries adopted this lockdown, but without really sufficient preparation to mitigate the consequences of these lockdowns. Next. So Uganda instituted lockdown measures in March, actually 18th March. And the hard lockdown actually started the end of March, 31st, where really a lot of restrictions were imposed. And Uganda was rated at that time at 90% stringent level of mitigation measures by Oxford COVID-19 government response tracker. The lockdowns delayed transmission, but this came at a heavy cost. Next. So we are really specifically looking at the patterns of this pandemic along the different timelines of intervention, and then looking at the secondary health effects of the pandemic, and then also assess the effects of the response to the pandemic on their service delivery. Next. So the method is, this was part of my country study to really look at the nature, scale, and scope of the indirect effects of COVID-19. So we really took up like case study, but case study which has really a mix of approaches. We do a scoping review of reports, media, and records, and more to dig up anything that's relevant to this work, and also do second analysis of HMIS data using interrupted time series, just as the Kenya colleagues have done. Next. Next, please. Yeah, so this is the, these are the interventions, major interventions the country really undertook. You had around from 31st, you had a very strict lockdown with a curfew, and actually you're not supposed to leave your homestead. And then later on, there was the easing of this lockdown. And on 4th of June of last year, they lifted a number of measures, and people were able to travel, but then with the curfew remaining, and also a number of vehicles could move with half capacity and so on. So it was a little bit relaxed. People could move, but with some restrictions. Next. So you note also the epi curve, how it has grown over the time. This time of the peak, you can see it had the 2 peaks, and it's a bimodal curve. And the latest high peak was around the elections. Next. So from all these media documents, reports, and so on, there is evidence to show that there were reported delayed initiation and treatment cycles for those with chronic health conditions like cancer, like TB, like diabetes, and so on. It was recorded by media and also some writers. There was reduced health workforce and logistical challenges for drugs and supplies. Next. Poor individual health status as a result of sedentary life was registered. There was a lot of alcohol consumption, even when there was such lockdown. And the violence in implementation of COVID-19 restrictions. People died as a result of these restrictions. Implementation of these measures. And there was registered increased distress and disease progression and mature death. Next. Teenage pregnancies were really, really high. One study found out that increased domestic violence and child rose so high, and then you had more than 5,000 recorded in the first month of lockdown, which is really, really quite high. And more than 2/3 are estimated to have experienced worsened food security. Next. So these are the other problems, health-related, which eventually are a health problem. These are the police brutality. You had so many people who were maimed. And yeah, people got so many problems. They are beaten, they go to the hospital, the pregnancies, you have, you had abortion, unintended abortion, and so on and so forth. So we had so many problems as a result of this police brutality. Next. Now, analysis of HMIS data. Next, please. So you can see we had a drop in number of people accessing health facilities. And so this is what we observed. That's what we got from this, the HMIS data. Next. And there was a drop and rise in cases of, in the case of malaria OPD. So which was really quite significant. And remember the interrupted time series analysis really compares the trend and levels before and after the intervention. And again, our intervention month was actually March. It was March, that's when all these lockdowns and other measures, strict measures were really taken. So you can imagine March and 12 months before, and then you have April and the following month. All these were compared and found a significant difference with malaria and also immunization. Next. There was also a significant change in trend of hypertension death. And also the number of malaria deaths reduced also significantly. And one may wonder why the malaria death reduced. It's just because institutional death where the number of institutional death was much reduced during lockdown because people are not coming to the facilities. So that's what, that's an explanation for this. Next. And then maternal mortality, also the registered increase in maternal mortality you can see. And then in May there was a drop. But again, also you have to, well, this could also be true, but you also have to think of the issues with the quality of HMIS data. While we think is fairly good, there are still some issues, but you can see that really maternal mortality generally was quite higher in 2020 and around this intervention time compared to 2019. Next. Attempted suicide. So you can see there's been really a rise compared to last year. Attempted suicide cases really much higher than before. Next. So even GBV, you can see GBV shortly after instituting these measures, you can see the number of gender-based violence cases. They really rose up. And this is also significant by interrupted time series analysis. Next. So what do we conclude from all this? We definitely will see that public health responses to COVID-19 should be prioritized, yes, because COVID is deadly, COVID is all over, and we have to really do something about it. But prior mobilities should not be deprioritized. you have immunization among the priority things. You have the cancers. Some cancers really have so much attention. They have previously had so much attention, such a budget allocated to them. But the moment we enter into COVID, it's like they forgot all the other things. While we're not saying that every other illness has to be, the budget has to remain the same or the attention has to remain the same. No, but at least one has to be very careful. Let there be some kind of caution with attention on some of the mobilities. Now, public response to COVID-19 needs to be evidence-based. Just hard restrictions disrupt services, and this can be devastating effect on the health system. Then there's a need to explore cost effectiveness of other prevention methods that work in our own settings besides lockdown. The governments in resource-limited settings like Uganda need to invest in systems that capture mortality data from communities. So you can see, when there was this lockdown, we couldn't capture, the system could not capture death in the communities. And so most people die, I mean, many people are dying actually, but not recorded at the facilities. So we need to invest more in proper enforcement of COVID-19 response measures. Having people are not trained enough to handle COVID cases. I mean, curfews, for example, it's a problem because you're going to get a woman who is going to deliver in a hospital, and then somebody manning a checkpoint is going to beat up that woman, thinking that she's just refusing to observe the curfew, when actually the problem is pregnancy or some other kind of problem. Next. So we are so grateful to the Center for Global Development. We're also grateful for University of Johannesburg, who were the Institute for Future of Knowledge. These were the prime recipient of this grant. And we're also grateful to the School of Public Health Management because they manage this grant. I mean, they are people who sign off, who observe, who supervise everything we do in at the School of Public Health. Next. Thank you so much, everybody, for your attention.
Great, and thank you so much, Naz, for painting such a picture of what's been going on based on both the media and the findings from HMIS. It's really interesting to see the comparison between what you saw in Uganda and what we're seeing in Kenya from that case study. We're now going to turn over to Mr. Stephen Kabwama, who will share some of the work that he has been doing with exemplars in global health on the maintenance of essential health services during the COVID-19 response. He'll be drawing upon some preliminary findings from the DRC, Nigeria, and Uganda. Stephen Kabwama is an epidemiologist by training, and he works as the training manager on the Makerere University School of Public Health CDC Fellowship Program. Stephen, take it away.
Yes, thank you for that introduction. So I'm going to present an overview of the exemplars in global health approach with preliminary findings from actually 4 countries: Uganda, Senegal, DRC, and Nigeria. Next slide. So the exemplars in global health program started in 2017 out of a simple question, really trying to understand what works and whether we are learning from it. So if we know what works, then findings can be synthesized to guide decision making, specifically identifying positive outliers or exemplars and analyzing what they do. Other countries can learn, and recommendations from these can emerge. Next slide. So the exemplars in global health work with a wide range of partners to conduct rigorous research. You see in this slide, for example, stunting reduction, mortality reduction. There is some work on vaccine delivery. So findings are synthesized across countries in order to generate these recommendations that are able to drive impact. The coalition of partners involved with our COVID-19 response, which I'm going to present today, includes Makerere University School of Public Health for the work in Africa and the Johns Hopkins Center for Health Security the work that will be done in Latin America and Asia. Next slide. So the objective of this work was really to document strategies and policies that countries are implementing in order to ensure that health services continue during the COVID-19 response. We hope to synthesize these findings across the countries in order to develop actionable recommendations. The in-country research partners for the African region are the University of Kinshasa in DRC, the University of Dakar in Senegal, and the University of Ibadan in Nigeria. Next slide. Yeah, so this slide presents the framework that guided our thinking and approach, and we considered that public health emergencies occur within a broader health system context where like initial investments in these systems determine the extent to which either services will be disrupted or maintained. Responses involve non-pharmaceutical interventions such as the lockdowns and mobility restrictions, but also health system interventions. And these two work in tandem to ensure that services are maintained in terms of people actually getting the services in terms of utilization, but also that the quality of the services doesn't drop. Next slide. So across the 4 countries, they implemented various non-pharmaceutical interventions to combat the spread of COVID-19. These include mobility restrictions such as curfew almost across all the 4 countries, measures in public places such as school closures across the 4 countries, supporting vulnerable populations such as payment of utility fees that was done in Senegal, provision of food relief in Uganda. And as you can imagine, these various interventions have both direct, indirect effects on health services continuity. Next slide. So these graphs show trends in health access for Uganda using health facility data. And what you will notice is similar to what has been presented by the previous two presenters, that there is a drop, an immediate drop in service utilization towards the end of the first quarter of 2020, probably due to the movement restrictions and other interventions. And the other observations we will make is that the magnitude of this drop is not the same across all 3 indicators. And for DPT3 and facility deliveries, there is a recovery after April, but for new attendances, that recovery seems to be slower, meaning that depending on the indicator you look at, there are likely to be varied disruptions in service delivery. Next slide. So in the next slide, I'm going to go over some of the cross-country challenges and interventions that were implemented by these countries. And in terms of governance, the first issue was really lack of comprehensive policy guidance on how to maintain services. In Senegal, for example, the guidelines were only on maternal and child health services, and where guidance was provided, like in DRC and Uganda, it wasn't accompanied with funding to operationalize the guidance. In DRC, there was also limited dissemination of these guidelines. So the recommendations and lessons learned are really that it's important to provide clear policy guidance and preferably as part of fairness efforts so that the guidelines are there before these public health emergencies occur. And then the dissemination should be at all levels of the health system. The other recommendation was to establish committees to coordinate the health services continuity. And to disseminate, if guidelines are developed, they need to be disseminated to all levels of the health system. Another intervention was the media campaigns that were conducted, and this, especially as we face new waves of COVID-19, to be done in tandem with along with the other messages of observing the SOPs. Related to health workforce, the challenges were the mobility restrictions that limited even the health workers, leading to absenteeism. There was reassignment of workers like we saw from the team from Kenya away from routine service delivery, and then infections and pathogens among health workers. Innovations were training using virtual platforms, provision of regular testing to health workers to quickly identify those they seek, provision of psychosocial support. So countries really need to invest in building their such capacity, their health workforce such capacity to avoid this or minimize the reassignment and repurposing during emergencies. Then also there was provision of free transport, free accommodation, which can be provided to health workers to address issues of fear and demotivation. Next slide. Related to financing, although countries received funding from donors and governments to support the response, this funding usually went to procuring kits, supplies, and little was provided to maintain services. And then also the movement restrictions affected funds disbursement for government, but also for implementing partners. Moving forward, countries can establish certain frameworks that can allow for the private for-profit and the non-for-profit institutions to contribute to disease response. Then financing for disease response should support activities for members of services such as the monitoring of the indicators, but also communication about health services continuity. In terms of health service delivery, the challenges were the movement restrictions that affected the patients themselves, suspension of important delivery models such as community outreaches, and then the perception of risk of infection in health settings, especially where health facilities house COVID-19 treatment units. These were addressed through use of telemedicine, such as in Senegal, was directly observed video therapy, phone follow-ups in Uganda and DRC, multi-month drug dispensing, introduction of new service delivery models, such as integration of gender-based violence services into ANC, and then leveraging the community health workers. Next slide. In terms of infrastructure, the challenge was repurposing of space to create, for example, isolation units. In Uganda, several mental health units were repurposed to make isolation units, and then there were stockouts of commodities such as IPC, commodities, gloves, family planning supplies, and then stockout of vaccines, HPV vaccines in Uganda. These were addressed through strengthening triage, provision of IPC commodities for health workers, and then ensuring observation of the SOPs in health settings. In Uganda, health facilities were designated for COVID-19 services, which allowed for continuity of services elsewhere. In terms of health information systems, the challenge was poor monitoring of health services disruption due to the movement restrictions. This was addressed through in DRC, they established monthly data feedback meetings, and then tools were provided for reporting in Uganda. Thank you.
Great, thank you so much, Stephen. It's just a really nice complement to some of the country case study findings that were presented earlier, as well as some really interesting recommendations coming out of the cross-country analysis. So for our last presentation, before we turn over to the panel discussion, we're going to hear from Petra Bergier, the GFF lead for knowledge and learning and results-based financing. Petra oversees the GFF's monitoring of essential health services in GFF countries in the context of COVID-19. Petra, over to you.
Thank you, Carly, and thank you for giving the opportunity to share some of the findings from the latest analysis available from the GFF side on how we support countries to monitor essential services. Next slide, please. We raised the alarm early on together with our investors group to highlight that there could really be emerging secondary global health crisis from disruptions in primary healthcare due to COVID-19, and also developed policy briefs, and supported countries through a learning program that brought out a lot of suggestions, including a lot of the ones we heard from the exemplars just before. Next slide, please. We have an approach to monitoring essential health services that encompasses 4 different components. The first one is, like we saw from many other colleagues, we leverage in-country HMIS data reported by health facilities to assess the magnitude of the change in utilization, and then to complement that with their support for implementation to rapid phone facility assessments, which makes monthly phone calls to representative sample facilities. So we get more timely data, as there's often a time lag with the DHIS2 data, as well as some qualitative contacts on supply side challenges and disruptions. And then we triangulate with supplementary data, which is linked to our resource mapping and expenditure tracking data, which really looks at the financing of the health system, as well as demand-side surveys that are led by the Poverty and Equity Global Practice of the World Bank. And of course, in country, there are other complementary efforts like the ones we've been hearing so far. And all of this is really to promote discussion and learning and action at country level and to contribute to the global knowledge. The next slide shows where we are supporting countries in monitoring essential services through HMIS data analysis support and the monthly phone facility surveys. We're part of the Act A health system connector. So as part of that, we've been working with other partners to align the tools and make sure we're collaborating from that perspective. So these are all the GFF countries, and the one in red are the countries where we're supporting phone surveys as well as the HMIS analysis monitoring. And then the green ones is where the HMIS is being carried out at this point in time. So let me share on the next slide some of the initial findings related to this. I think as we've been hearing from many others already, the data really reaffirms significant service delivery disruptions. We see that the service gaps range from 7% to 64% during the March to May 2020 period, when we look at the 18 monitored GFF countries. But what we also see is very much that the pattern of disruption differs between countries. So we see that some countries are experiencing persistent disruptions, like for example, Nigeria and Sierra Leone, whereas others experience large acute disruptions with some level of recovery. However, we also know that many countries are now facing higher second wave of COVID-19 infections, and that there's a threat of these being more lethal and transmissible. So that's really important to keep in mind. What we see on the left here was a volume of outpatient consultations, which is a proxy for services and really shows the disruptions. From the other aspect that we see is that the RMNCH services, again, it's very context dependent, but that the recent disruptions are really underlying inequity. So we see that there was a brief return in the third quarter of 2022 to RMNCH services as prior levels, but that in the last 3 months of 2020, there were disruptions again. We also see that urban areas are more likely to be experiencing substantial and prolonged service disruptions, which implies that looking at the national level really may mask underlying inequities. On the right, you see some significant differences by country, but I won't go into the detail just to show some examples. Next slide, please. The phone surveys really highlighted alarming vulnerabilities in infection prevention control and weaknesses of existing health systems. In Nigeria, we saw that only 1 in 4 facilities reported not having a mask on hand in December still, and only 1 in 2 facilities reported having received training in infection prevention control or the use of personal protective equipment. In Liberia, 1 in 2 had enough masks or gloves for clinicians, and 97% saw a decrease in the service delivery in November due to supply chain disruptions. This really highlights the systematic weaknesses and the poor pandemic preparedness in health systems, which pose a threat to the future continuity of services. Next slide. This really shows a map of our countries again, but looking at the resource mapping and expenditure tracking. So in collaboration with other partners, including WHO and others, we have been supporting our routine resource mapping and expenditure tracking, as well as looking at COVID-19 resources availability, as well as a deep dive in some countries for reprogramming. Next slides. What we see is that the financial resource needs are great. The RMED data shows that there have been significant budget commitments for COVID-19 response plans, and that is done while recognizing many countries already had an existing funding gap for their investment case or health plan prior to the onset of the pandemic. On the right, you see that in-depth analysis of Chad, DRC, and Niger shows that funds for essential health services have been reprogrammed towards COVID-19 response. And in most countries, the COVID-19 response plan have not yet included the cost for the COVID-19 vaccine rollout, which will make the needs even greater for countries. Next slide. This shows the GFF countries where we're supporting, where household surveys are being carried out to monitor demand side challenges and assess the impact on health-seeking behavior. Next slide, please. We see that the pandemic's impact on lowering demand of essential health services is significant. In the most recent surveys in 16 GFF countries, we see that about 25% of the households who reported needing healthcare could not access it. That was in Chad and Senegal, while in 7 other countries, this was over 10%. And the most significant reason for foregone care across the countries was financial barriers. As you can see on the right, the green highlights the financial barriers. And given the global economic downturn and its impact on increasing poverty, we expect that this will only get worse. The projected economic shortfall in GFF countries, we project may lead to an increase of 5.5% in overall infant mortality, because households will have less money to access care, as well as nutrition practices and other aspects. So COVID-19 has created or exacerbated financial barriers to healthcare, which are being the most acutely felt by the poorest and the most vulnerable households. Next slide. It's really important for us to continue supporting GFF countries, but also to ensure that this data is used for decision making, as I also heard several other speakers allude to. Next slide, please. Some examples of the data use at both country and global level. So it's really this data or the monitoring, it's not really a study what we're doing, we're supporting countries in the monitoring of what's happening. And this is really because we think this data is critical for country platforms to use and to decide on actions and strategies to deal with the challenges faced at the country level and assess the barriers, including resource allocation. So we see that country platforms have shared results with a wide range of stakeholders, including donors, technical agencies, and CSOs to inform decision making. For example, in Nigeria and Somalia, this has been used to inform development of targeted guidelines for maintaining essential health services. And in Liberia, there is more money going to the front line to deal with some of the challenges. Ethiopia, without using the GFF data, already had a very good system. We learned a lot from Ethiopia, and they convened weekly meetings with the regional health bureau heads to review data and really prioritize areas for supportive supervision and targeted mentorship. We also really want to ensure cross-country learning. So through the Service Delivery Learning Program, we had country teams from 18 countries review results, learn from each other, and develop plans to maintain essential health services during the COVID context. We're using these findings also to help inform the design of our essential health services grant. And we also want to learn from these innovative approaches applied through this work to help inform how to most effectively support countries to strengthen rapid cycle monitoring and real-time use for decision-making and program improvement. My last slide highlights that really there are several looming threats that face GFF countries. Firstly, there's the continued disruptions in essential services in view of the second wave of COVID-19. There's the vaccine rollout that will place severe strains on the health system and health resources. And there's the economic constraint that will impact the ability for vulnerable households to pay. All of this impacts the ability to deliver essential health services and for vulnerable households to pay, which will affect many of the gains that have been made in the past. So we're using this data also to inform bank GFF projects, including health services grants, which are part of our current vision to really ensure that countries reclaim the gains, and also highlighting that the financial barrier data shows that we need to broaden and deepen the engagement with countries on increasing financial access and equity by developing and implementing more effective and efficient models of delivering healthcare that will reduce costs and improve access for the poorest and most vulnerable populations. For this reason, we're also in our resource mobilization mode to really try and gain more resources for countries to be able to support them in this challenging time. So with that, I would like to end it here. Thank you.
Great. Thank you so much, Petra, for sharing all the work that GFF and the bank are doing, both leveraging data to try and inform policy responses, but also supporting financially and technically various countries to really address essential health services. Thanks to everyone for incredibly rich and informative presentations. With the remaining minutes, I'd like to welcome our esteemed colleague, Professor Rhoda Wanyenze, the Dean of the School of Public Health at Makerere University, to facilitate a discussion among the panelists and address some of the questions coming in from our virtual audience. Rhoda, over to you.
Thank you so much to all the presenters for these excellent presentations. There is a lot we can learn. We have quite a number of emerging quick run through this. To begin with, we have some questions from Shafang, Zhang, to Stacy, and Jacob on your presentation. The question is, what do you think are the most effective preventive interventions for COVID-19 in Kenya, or is it, might it be difficult to tell from your experiences so far? And what do you think are the most important aspects that funders could focus on to support the COVID-19 response? And I will also take the question for Nazarius from Zang as well. What do you think are the suggested cost-effective local preventive methods to slow the COVID response besides the lockdown? And the same question also goes to Zang, brother to Jacob and Stacy. So we can take this and then get back to the rest of the questions. But I will also cover one to Petra from the experience across countries. What do we learn from the countries that had the least disruptions? Because you show us variances between 7 to 64% in terms of gaps in service delivery across countries, with the biggest disruptions in Nigeria and Sierra Leone. So what did these countries not get right, and what do we learn from the countries that had the least disruptions from your experience? And also, based on your experience, especially since you also looked at the issues around financing of the health system, which we don't see from the other presentations, where do you think the biggest gaps are in terms of investments in the health system? Because it's quite broad. There are a number of issues that we need to look at here. What do you think are the most critical investments in what components of the health system that would give us the best results in terms of disruption of essential services? So we can take this for a start, and then we'll get back to the next round. Thank you.
Thank you.
Jacob and yes, and Stacy. Thank you.
Thank you very much, Rhoda, for the wonderful questions. If I may go first, two key questions, and these are very essential. what we think could have been the most effective measure that the government implemented. I mean, it's not as clear as it may sound that one measure was more effective than the other. But on top of my mind, I think the implementation of the physical distancing measures that the government of Kenya implemented, as well as, the sanitation and hygiene measures, washing of hands, wearing of masks, ensuring you maintain that physical distance, could be the top most effective measures that could have slowed down the effect or transmission of COVID-19 in Kenya. Again, what should funders focus on? I think we have very good researchers in Kenya, but there's a funding gap into research. So perhaps more funding into research and perhaps more funding into vaccine research, as well as evaluating, these interventions. So maybe my colleague Stacy can add.
Okay, thank you. Stacy, would you like to add to Jacob's response?
Maybe just to add on the first point and to emphasize that it might be difficult to disentangle which of the non-pharmaceutical interventions may have had a greater impact because they were implemented more or less at the same time. So it becomes hard to disentangle their measures, but we do see a relation between relaxation of the non-pharmaceutical interventions with a rise in cases over time. Thank you.
Yeah, thank you so much.
Thank you.
Oh, yeah. Thanks, thanks, Prof. Rod. Now, you can say our recommendation says we need to explore other cost-effective measures. And some of the measures we think can work, but which can work beside lockdown. Lockdown, we think really we may have to be very careful imposing a lockdown because there are other, just supervising the hygiene practices, supervising that this gathering has too many people and doing this professionally. I think that can work because we've seen a year after these hard lockdowns, we've seen people still observe curfew. There's a big jam in this country in compared towards 9 because people are trying to make sure that they are at home before the curfew. So a professional enforcement of this, not this enforcement of beating people, of shooting people, that can work very well. People can observe these rules if they are monitored, if they are checked, and when this is done very well, things should work out very well. And also people should have noticed that actually COVID cases have reduced, although we are also waiting for the second round, second phase, but partly they have reduced partly because we're trying to observe the rules and regulation of COVID. So it's not a whole lockdown only, which can work, but there are other ways to actually do the similar work. And I've given you one example. Thank you very much. And my colleague Claire may want to have just maybe may want to add anything. Chair, if you can allow. Claire, would you want to add something? Okay, maybe she's not. Okay, that is it.
Okay. All right. Thank you, Nazarius. I wish and hope if you know, you can advise us. But how effective are these other measures? What is the level of compliance, and what might be the effects if we chose to do the distancing and the masking and hygiene? And what results would it give us? I wonder if you came across anything in the literature that shows us how well these work in comparison to the lockdowns that we are implementing. That would be a great addition to the discussion. Is Claire that as well? Okay, as we wait for Claire or any other member, we could hear from Petra as well. Petra, what did we learn from the countries that had minimal disruptions as opposed to those where we had very severe disruptions, given that we see a range of 7 to 64% in the data that you showed, you shared with us? And where would we have a focus in investments for the health system to make disruptions for the future?
Thank you. Very important points. So I think there are a couple of factors. I think the lockdown and other limits on mobility, as we've heard from other speakers, has really had an effect, and the measures that countries took differ. The level of financial barriers, I think, was also is also context specific. Fear of COVID very much affects the access or people utilizing services. Also, in countries where, with previous experiences of Ebola, we saw sometimes an earlier disruption, but sometimes also a faster recovery as the use of community health workers and so on really helped to address some of the challenges with maintaining trust and ensuring access to services. Of course, disruptions in the supply chain for essential commodities are an important part, as well as the strain on the healthcare workers. We saw some facilities were closed or reduced hours, with also healthcare workers having fear sometimes, which affected it. And then, of course, the last point about the reallocation of resources for COVID-19 also is not has hampered in a way some of the essential services in countries. So it's really context specific, but very important to look at these aspects to decide on what is important. So where should we invest? Well, a couple of things. I think the essential monitoring is really important, and using this data and more rapid data to really inform actions is, I think, a very important aspect. So that's something we really think about is critical. And then also really ensuring a dedicated focus on essential services. As we saw initially in the pandemic, that was not necessarily on the radar of many countries. They were so focused on the possible COVID response. And currently that's with the vaccination coming up, another risk again. So this is also where I think why we're focusing on trying to mobilize more essential health services grants so that we can leverage IDA for health system strengthening and COVID-19 response and vaccine rollout. And that's really to help remove some of the system bottlenecks to facilitate the delivery of the COVID-19 tools and maintain essential services, but also really thinking about the longer term resilience of the health system. As well as what I think I mentioned is increasing financial access and equity. So it may require some different ways of doing services and redesigning the way that services are being delivered in country in line with some of the suggestions made by other speakers already. I hope this is helpful.
Okay, thank you. And I don't know if Claire is able to comment, but this goes to everyone, and we'll start with Stephen. As we get into second and perhaps third waves in some of these countries, what would you advise policymakers to do to ensure that we don't have these disruptions again moving forward? And it's open to the other members to comment, but also the key question is alternative interventions. We have had several suggested, distancing and the masking and the hygiene. And I think Nazarius has talked about some more professional monitoring of some of the restrictions. So what do we think we should focus on? Because we might have another wave. What do we do? If we don't want to lock down, what should we be doing? So Stephen, I hope you got the first question about your advice to policymakers. Should we have a second, third wave in these countries or other countries? How should they be prepared to avoid disruptions?
Yes, thank you very much, Professor. I think to policymakers, first and foremost, they have talked about the monitoring and to come up with interventions basing on the monitoring of these data and the disruption of services, so that the interventions are informed by data analysis of how health services are being either maintained or disrupted. I'd just like to comment on what you've talked about, what interventions are really to be recommended in case we have another wave. And I think assessing how far or how effective we've done in terms of maintaining services and looking at those interventions that have worked. Case in point, in the work we're doing, I think the use of community health workers has been quite effective in terms of filling that gap where patients couldn't access health services. But also looking at other interventions that have come up as a result of COVID. One of them is the dispensing medicines for multiple months. So again, this can minimize the number of times people have to go to the health facility. So identifying those interventions and continuing with them will be effective in ensuring that people continue receiving their services. Thank you. Oh.
Thank you, Stephen. Any other quick comments from Petra and Nazarius? We have only about 2 minutes, unfortunately. If you can do 1 minute, Petra, for the countries, in terms of preparedness, where should we be focusing for the second wave? What should they do or not?
Thank you, Rhoda. In fact, I would say we have quite some learning nuggets related to this on our website, globalfinancingfacility.org, and then go to learning about strategies to keep clients safe, to change how services are delivered, to make changes to enable necessary visits to health facilities because they are still necessary, but also to think through how to reduce the unnecessary visits in the health facilities, and really how to implement and monitor those changes to maintain essential health services. Because there are many strategies that could be used, and I think Stephen elaborated very well on some of them, some of the examples. Thank you very much.
Okay, thank you. And
I think we are coming up on our time. I know we're actually a little bit over. So I did want to just thank everyone who presented today and Prof. Rhoda for facilitating our somewhat abbreviated Q&A session. Please do check back with CGD and check out partner sites on all of the ongoing research in this space. And stay tuned for additional events in this series that will be presenting more country findings on COVID's indirect health impacts. Also, stay tuned for a soon-to-be published paper that examines this type of evidence on indirect health effects with a gender lens that will be coming out from CGD next week. So thank you all for being here as part of our virtual audience. Thanks to all of our presenters and participants, and I hope you all have a wonderful day. Take care.